Thank you, Heather, and thanks to the organizers for this wonderful opportunity. So I thought I'd start by mentioning if any of you don't get a chance to ask questions and want me to clarify, it's fine for you to email me. So my email is jim.loyd@vanderbilt.edu, and I'd be happy to talk with you about IPF and families or any other of the features related to our work with IPF. So it looks like this one doesn't work. Well, maybe we won't. Let's see. So how do I advance the slides? The handheld doesn't, the arrows don't. Can you advance the slides?
There may be a better expert than me.
This doesn't seem to work. Nothing seems to work. We'll get there. Be patient with us. Okay, here we go. So I thought I'd start by a few slides from what I think is an excellent reference, and I would recommend to any of you in the room. So it's the genetics home reference at the website there. If you Google it, it comes up. And so I've learned a lot from that website. So it's the NIH, NHLBI is with the National Library of Medicine put together. And I'm going to show you a few of the questions that come up under a few of these. We won't have time to go through all of it, but it's really very well written and very comprehensive. And I think, so any of you who have questions about genetics, I think that's the first place to start, the genetics home reference at the NIH. So these are some of the topics under Help Me Understand Genetics. And then under one of those, mutations in health. I'm not going to ask you to read all these, but just a couple. What kinds of gene mutations are possible? What information about a genetic condition can statistics provide? How are genetic conditions and genes named? So they're really comprehensive. Here's one, inheriting genetic conditions. What does it mean if a disorder seems to run in my family? What are genomic imprinting and uniparental disomy? Kind of complex issues, but may be important in certain circumstances. Are chromosomal disorders inherited? So this is a very well-written and I think wide resource that is very helpful. Genetic consultation may be appropriate to many of you who might be in families, some of whom might have had a mutation discovered as more are being discovered. So what is a genetic consultation? What is the prognosis of a genetic condition? How are genetic conditions diagnosed? So I think this is an enormously useful resource, and I'm very supportive that the NIH and LBI have founded it, and I think it'll probably grow and evolve as we learn more. It's not specific to IPF in any way. I think IPF is mentioned there and interstitial lung diseases, but for learning about genetics, it's really an excellent resource. And so I don't know how many of you were at Mr. Jeff Trent's second talk yesterday in the plenary session, but it was a superb talk, and he talked about how every one of us, every person in the room, myself, can be expected to have a dozen or up to 50 different major genetic mutations that, given the right circumstances, might reveal themselves and cause disease. And so it's not that any of us are free from genetic mutations. And so telling when a variant in a DNA change actually predicts disease, the most helpful information is in the second point. And so if there's a family history, then that coupled with a genetic mutation tells us what's called the clinical expression of the disease. And that's the critical feature in any family. So family history is critical, knowing which of your aunts, uncles, cousins might have had something in the lung disease category. We'll talk momentarily, for instance, about the telomerase genes. And I have to admit, when we started, we only thought that diseases in the lung would be important. And until 2007, we missed it completely for liver disease or bone marrow disease because we didn't think that would be relevant. So even things that you guess might not be relevant can be, and family history is the critical feature of knowing whether those mutations that we carry are likely to cause disease at some time. And this chart shows in green the disorders for which genetic tests are available from gene tests, and shows that there are nearly 5,000 different disorders that can be gene tested in, and the rapid escalation of those, there's probably 20,000 genes in each of us, and so probably most of those 20,000 will eventually be found to have changes that may be important to some diseases or others, but it's an enormous proliferation of genetic knowledge, as Jeff Trent gave a wonderful review of, and how he had participated in the human genome research. And so this is useful and important information. I don't know if we could have the lights down slightly in the front if it's possible. The slides might show better. So in my view, genetics of IPF begins with Dr. Phil Bonani, who spent half a century, I think, as an internist at the University of Rochester. In 1965, happens to be the year I graduated from high school, Phil was hard at work as a medical resident, following up on a family that had 8 patients in Rochester, which was barely conceivable at the time. You'll see at the left, there are 2 twins represented by the common signal. And a mother and daughter had been reported in the early 50s from this same family, but Phil did a meticulous study and followed up on it. And so when we became interested in trying to work with families with IPF to understand a basis 20 years ago, I called Dr. Bonani and I said, I kind of called him out of the blue. One of our residents had worked with him earlier at Rochester and said, he's a great guy, call him up. And so I did. And he said, yes, I still follow a gentleman in that family who'd be happy to work with you. Phil had followed him then for 30 years after his report of that family. And one of the members of the family actually made a donation for us to begin our work with families. And Annis Marney, a medical student, then followed up on the family and reported them at one of the big lung conferences, the Aspen Lung Conference. And just that one family that had 16 patients to date at the time with IPF, we believe, showed characteristic features that tell us that mutation in just one gene is sufficient to cause disease. So that's autosomal dominant transmission is represented by vertical transmission all the way to the left in 4 generations. So autosomal dominant penetrance, we presumed, was a participant in many or most families from the start. And that was in 2001 when Annis presented that report. The very following year, that support from one of the members of Family 23 led to one of the most important discoveries, I think, by a brilliant fellow, Alan Thomas, who was working in the genetics lab of John Phillips at Vanderbilt. With the red arrow points to the proband in this family, who contacted us and said, I've had 10 cases of IPF in my family. I'd like for you to work on it, if you will. And so she recruited several patients in her family to donate DNA, and Alan tested the surfactant gene, surfactant protein C. That year, a report from Cincinnati reported a 16-year-old mother with NSIP and a child with DIP. And so at that time, this is our family 34, was the only of 60 families that had children involved. So Alan selected this family to test for an SFTPC mutation and found it, a different mutation in surfactant protein C. So that's especially important for a variety of reasons. This family had 3 children at the time, onsets at age 1, 3, and 5. 2 of the children are still alive, and 12 adults with IPF. So I think it was the first gene for which IPF was reported, and knowing that surfactant protein C is a basis for IPF in some patients and families is pivotal from the scientific viewpoint. So in the left panel is a normal type 2 alveolar epithelial cell. You can see the arrows pointing to clear lamellar bodies that release the surfactant, and these cells are stained. The brown is pro-surfactant protein C. And you can see the patient sample at the right, the distribution of the brown staining involves all of the cytoplasm. It's a very different picture. And so SPC is made in one of the 40 different cell types in the lung, and you can see how different those cells are. And so this was really an arrow right to which cell is abnormal in some forms of IPF, and led our group and others to focus on misfolded proteins in alveolar epithelial cells and ER stress, and other types of biology that are important. SPC is a very important cause of disease in children and young children, and the mutations may happen all the way across the gene represented here. This is an old slide. There are many more mutations since that time. There are many exons, and so it's a fascinating disorder that has characteristic features, including onset in childhood, even 1 or 2 years old, as I've shown you. So anytime a child develops interstitial lung disease, that's suspicious for SPC. And the other feature is shown in this different report from Dr. Nogia and Cameron 10 years ago. And in red is the survival of different individuals with interstitial lung disease as old as 55 or 60 years before lung transplantation. And so it's surprisingly how long the survivals can be in individuals, even with significant disease. And Dr. Nogi, who's the world's leader at surfactant protein C mutations, describes the waxing and waning course. So patients will get worse when they have a respiratory viral infection, may then subsequently improve over weeks or months and get off of oxygen. And in the original family that Alan Thomas reported, we had one fellow who had 50 years, had onset of disease at age 5, had many different diagnoses. At one point was called sarcoidosis, but eventually at age 55 succumbed to the disease and clearly had IPF by tissue samples. And so a very long course or childhood onset are characteristic for surfactant protein C. You heard yesterday from Christine Garcia, who's done wonderful work with telomerase mutations. We'll talk about that momentarily. But she also discovered another surfactant protein, A2, is important. And so it has some different features, I think, and it's still being worked out. Both SFTPC and SFTPA2 are completely different genes and phenotypes. And those are rare causes, but they're very important for medical sciences. And of course, for those individual families, they're paramount as to what the features of the disease represent. So that's the surfactant genes at the bottom, SFTPC and A. The vast majority of genes that we know to date are in the telomerase pathway. So telomerase reverse transcriptase, you heard it mentioned at the session we were just in where a patient reported that her family has TERT found by Christine Garcia. The second most common is RTEL1, and then PARN are the three that make up the commonest cohort in the telomerase pathway. There's a list of other genes below that that again make up about 1% of the participants. So I mentioned my email. If any of you don't need to write a lot, I'm happy to send these slides to anybody. If you'll just email me, I'll send you the slide set so that you don't need to write a lot of this down. The genes that contribute to IPF, the telomerase pathway is by far the most important known to date, but there are other pathways that are of importance, of great importance. ABCA3 is one that's a recessive gene, so you have to have two mutant copies to develop disease. It's important in children, and its adult equivalent is still being defined. And of course, you've heard a lot about common variants in interstitial lung disease. The MUC5B or mutation gene, TOLIP genes, and others are important. They're harder to act on from the standpoint of predictive capacity because 1 in 10 people in the room have those changes. So they're less predictive about who might develop disease. But the telomerase pathway is by far and away the most important pathway that we know to date. So the telomeres are the caps on the end of the chromosome that protect the DNA in the chromosomes from being damaged by a DNA damage response. And there's a very sophisticated mechanism to maintain those caps. The telomeres are reproduced every time a cell divides, so all the way from when you're a baby in the womb until when you develop this, trillions of cells divide many, many, many times. And so each time they divide, then that telomere needs to be replaced. They generally decrease in length during age, and I'll show you the spectrum of that, but they're critically important for the cell biology. And telomerase is a whole series of enzymes, scores of enzymes, of which we know a dozen that may be related so far, but probably many others may make up the rest of the pathway. So a pivotal study was made by the other scientist who's made the major contributions to telomerase pathway and IPF, Mary Armanios at Hopkins. And so this is a family that had a very rare condition, dyskeratosis congenita, has been known for 100 years, but was very poorly understood until 20 years ago. It was related to telomerase mutations. So Mary was working on this family with dyskeratosis congenita. You can see at the top left is the open circle is a 65-year-old lady who died with IPF. She had children in their 40s who had cirrhosis, aplastic anemia, many other features of telomerase mutations. And in the youngest generation were teenagers and 20-year-olds with aplastic anemia, pulmonary fibrosis. So that has a genetic terminology called anticipation. That's where the disease gets worse or younger or has higher penetrance in subsequent generations. That appears blatantly evident in this one family that Mary reported, but fortunately it doesn't seem to participate in few or maybe none of the families. So we have 35 families at Vanderbilt that we know that have a TERT mutation, and genetic anticipation is a small or maybe not represented at all. So understanding why that happens in some families and not others with a TERT mutation is an important goal. But I think maybe the greatest importance of this family is that one patient in the top left made Mary think, well, if a lady in a family with dyskeratosis congenita can have only IPF without any other features, maybe families that have only IPF represented might be caused by mutations in telomerase also. And then actually we shared several samples from our Vanderbilt cohort that was built in part related to the patient donation a few years before. And Mary then in 60 families found 6 TERT mutations. 6 of them had TERT mutations, different TERT mutations, and reported that in the New England Journal in 2007. Here is from that paper a graph of telomere lengths of different individuals. So the red are ones who have the mutation. The black dots are ones who do not have the mutation in the same families. And you can see the curves. So the middle line is the 50th percentile. The top is the 99th. The bottom is the first percentile. So it represents all the different age-corrected percentile that, of course, are not shown on there. And you can see that the red, not surprisingly, the mutation carriers have very short telomeres. One of the things that's surprising is that some of the black dots, specific individuals may fall very low on their telomere length, and we'll talk more about that phenomena momentarily. So just from looking at the individual families, a skilled physician can guess whether there might be a certain pathway that's participating, again, young onset and long duration in surfactant protein C. And the telomerase pathway genes, dyskeratosis congenita can affect nearly any organ in the body, but lung, liver, and bone marrow are especially at risk. And so if there is a patient that has cirrhosis, or if the patient with IPF has cirrhosis, then that alone suggests that there might be a telomerase pathway mutation. But cryptogenic cirrhosis or bone marrow disease, either aplastic anemia or myelodysplastic syndrome, is a certain contributor in some features. So, for instance, this is one family we saw. We're seeing the gentleman in the top right with IPF. He had 2 older brothers with IPF, and they had an older brother with aplastic anemia who died from aplastic anemia, and the fellow in clinic said that must be a telomerase mutation, and he was right, as it was a TERT mutation shown there. And there was a different family, so this is all the way back to the mid-200 families, and we were seeing a patient with IPF whose younger sister had died at 30 with cirrhosis attributed to alcohol, possibly partly correctly. 2 older brothers with IPF in the dark squares. They had an older brother with myelodysplastic syndrome who had a son with aplastic anemia. So just looking at the characteristic features, this is the importance of the family history. An experienced doctor can look at that and say, gee, this is likely to be a telomerase mutation responsible for all of those different conditions. And why one individual gets aplastic anemia and a sibling gets, or an uncle gets IPF and another one gets cirrhosis, that is very poorly understood or not understood at all to date. But I think that working together via foundations like the Coalition for Pulmonary Fibrosis, we hope to make progress in understanding those vagaries. That's not at all unusual for genetic diseases to affect different organs, and so geneticists are not surprised at all by that pleiotropism, they call it, where the same gene defect may cause very different diseases in different individuals. And we need a lot more information to understand that feature. Especially the telomerase disorders have a confusing feature and a confounding feature both for individual subjects and for linking of genes to disease. And that's where, when all of us are created and born in the womb, we get our original telomeres from both of our parents, where the gametes join. So you start life with telomeres that you inherit directly, whether or not you inherit the gene mutation that's responsible in that family. So those are independent effects that's called epigenetic. And so the inheritance of telomeres versus the mutation occur independently, and telomere length is really the determinant of disease. But it's confounding because non-carriers may inherit short telomeres and have disease. Mary showed that beautifully at Hopkins in a series of mouse models where she created mice that had short telomeres with or without the mutation. And the mutation, basically, the telomerase function did not have any impact on the tissue renewal capacity. So these are elegant, wonderful animal studies that really help us understand the biology. Mary was working in the laboratory of Carol Greider, who in 1985, I think, discovered telomerase and got the Nobel Prize for it a few years ago. And so they really have made landmark studies that help to understand telomere biology. Christine Garcia at Southwest has done very similar studies in a similar time frame, shown in the red arrows. In her telomere plot of families with TERT mutations, you can see some individuals who don't carry the mutation but have very short telomeres. And Christine has shown that those individuals do have some mild lung disease. So I think this is an area that's very concerning to me because I think traditional genetic counselors, as you heard yesterday from Janet Talbert, who's an expert, around the country, I don't think it's being accepted that this phenomena might happen in some individual patients. And so my opinion is anybody in TERT families who's being evaluated for the possibility of developing future disease, then telomere length and the mutation status are important in determining their risk. So the occult genetic disease is not important just in counseling individual patients and families at risk, but also confounds linking a gene to a disease. Christine showed that very nicely with the latest gene that's important in the pathway, the PARN gene, and she showed that in epigenetic inheritance of telomere length really confounds or obscures the identification of that gene that's related. And so it's a problem that we should all take into account as we learn more about these diseases. Fortunately, telomere length is readily available, and we can draw a blood sample and send it out to a variety of different labs. There's 6 different approaches to measure telomere length, and some of those are more reliable than others. But we like flow cytometry, I think, as the most specific and validated method. Others may be good in some labs, but across labs, I think it's the best validated and the most specific. And as we learn more about these pathways, it's clear that telomeres are important in anybody, regardless of whether you have a mutation in the family or not. So they're a risk factor for IPF. They help represent the IPF survival at many different centers. And you've heard many talks at this conference about the importance of telomeres in biology of different interstitial lung diseases. So our experience in 600 families with IPF, or in working with IPF for several decades, is that about 1 in 5 patients who come to us with IPF or something like it have a family history. but they don't always know that at the front at the time they come to see us. And so about half or 10% are able to tell us that. As you heard yesterday, many physicians who don't deal with IPF routinely don't think it's familial, may have told a patient not to worry about their family. When they come to clinic and learn that a significant minority is familial, they'll go find their cousin's death certificate that has pulmonary fibrosis on it and come back to the second visit and tell us. So part of it is them learning about should they look for IPF in the family. And then the other half is, in part because I've been here for so long, patients may come back, or families of patients may come back, and I may happen to see them in clinic. And so 2 months ago, I saw a lady, a 65-year-old lady who actually happens to be a physician. Her cousin was at Vanderbilt 20 years ago for a lung transplant and had IPF. So it may be a long, long phase between when a patient has disease in a family and then the second case happens. And so that's the other 10% of the familial IPF that may be misrepresented as sporadic in presentation. So, and of all the families, about 20% have a known specific gene, the ones that we talked about, but 80% of the families still don't have a known specific gene. Any of you were at John Kropsky's talk yesterday, heard about 2 genes that are important in a few or a handful of different families that are not in the telomerase pathway, that are not in the surfactant pathway. So how many more question marks there are for those 80% of other families? I think it may be dozens of other genes. Many experts believe that because something like half of the family patients have short telomeres, that much of that 80% may be other genes in the telomerase pathway. But I think it's an exciting time to be watching the evolution of the science of IPF in families. And we talked yesterday about genetic counseling or genetic testing. So I think there's 2 major groups of application of genetic testing. So where it's traditionally used is when a family is known and then individuals without a disease want to know their risk. So if the genetic mutation is known, they can be tested. And then that requires a lot of genetic counseling to understand what the benefits and risks of knowing that an individual who doesn't have disease yet and might develop it, that requires a genetic counselor. And that's in contrast to a different application of the different gene tests that are available now. For instance, if we see a patient in clinic who has bronchiectasis, one of the common causes of that is cystic fibrosis, but you cannot necessarily know that from the front end. One of the simple ways to know it is to make a diagnosis in a patient. We can send a genetic test that looks for the CF mutations. If it's positive, then that confirms a diagnosis. So that type of testing, in my opinion, doesn't require genetic counseling up front. You're trying to make a diagnosis for a patient and their family. And so that's different. And I think, in my opinion, clinicians should feel less reluctant to give that offering to patients and families where there is a family history, especially if it has one of the phenotypes. So these days it's really quite easy to sequence the gene. You saw Jeff Trent yesterday in his wonderful talk said it took, in the Human Genome Project, it took 10 years to sequence the first genome. They can do it in 10 hours with one of the machines he has at TGen. And so it's very simple to do the sequencing now, and there's a variety of gene panels that are now available for all of the genes that I mentioned, and anybody can order that, and some of the companies that offer that are represented outside. And the expense has been covered by most insurers here to date, and the results, I think, are reliable. Sequencing is so good that getting the results is really straightforward. The clinical groups of IPF are patients that might be applied to are sporadic patients where the family history is negative, or to many times we may know that there's another patient in the family, but they don't have young onset or long duration or other features of liver disease or things that tell us the telomerase pathway. So those are kind of the 4 major distinctions. And so which tests we should use, I think a good argument can be made for measuring telomere lengths in the vast majority of those patients. They're widely available, they're inexpensive. So for instance, we do a lot of lung function testing. They're about fourfold the cost of what it costs to get telomere tests. And one telomere test kind of from the start tells us a lot about that individual. So I think as evidence builds, that the argument to test telomere lengths in many patients, certainly in families, if they are very short, less than 10th percentile, then I think that heightens the possibility that there's a telomerase pathway mutation. Whether we can identify that specific gene in the panel, that's not always possible, but new telomerase pathway genes are reported more and more progressively frequently. And so I think the genetic panels are especially important in those who have a characteristic phenotype, and that carries with it the burden, though, of all the education that we talked about. So the way individuals and families are typically counseled for other diseases, it's a three-step process. So this is individuals who don't have disease but may want to know what their risk is. They would go and meet with a counselor or talk with a counselor, think about it, go back a second time to have a blood sample sent off. That will take a few months usually to be tested. And then they go back for a third visit to get the result of the test and to discuss the implications. So it's a three-step process. When it's been looked at in other diseases, there's dropout at each stage after patients have thought about it. So it requires a lot, it's comprehensive and labor-intensive for the counselor and the patient. But I think all of those are important fashions that are especially important in counseling families. So the other important point is that beyond a definitive positive result, then the results are confounding and sometimes uninterpretable. So a positive test is really the only conclusive test. If there's a DNA change, as I've told you earlier, we all have lots of DNA changes. Sometimes that's a mutation, and that's very helpful and important, especially if then other fit members of the family can be tested to confirm it. But a variant of unknown significance means that we just don't know whether that change is important. Another important point is that even if a mutation is not found, that does not mean that one is not present. It just means that many may not be easily detected or not yet discovered. And so really the only result that's helpful is a positive test. How helpful is a positive test? What does that mean? Well, so if a patient has IPF, it may not change the treatment, in part because we don't have that good a treatment yet. We do have a couple that do have some effect at slowing it down, but of course what we hope for is to have specific treatments for surfactant protein C changes, which are going to be very different than those for telomerase mutations. And some of the talks yesterday talked about how you can lengthen telomeres or prevent loss of telomeres or upregulation of telomerase or other things. So I think for each of the different gene mutations, there may be different diseases. And for those of you, so that may have happened already in cystic fibrosis, a recessive disease, usually of young children, but the gene was discovered in the 80s. Finally, a few years ago now, there is specific therapy for the chloride transport that looks like it should prevent disease completely if it's applied early in the course. So I think there are good demonstrations of why we should have hope that this understanding is going to lead to new and more effective therapies. But it helps the family to know. Many families I find are enormously gratified that they've had this tragedy over their family for years, and now someone at least understands what it means. Some people find that frightening, some people find it encouraging, and it depends on kind of what perspective you take about that. But it does help patients to know, as you heard from the lady this morning who shared with us that she'd had a mouth cancer. So leukoplakia and mouth cancer is part of a telomerase mutation. So she knew to look for it, acted early, and acted on that. So it helps to know other organs and the disease course, especially bone marrow, liver, or other organs. And it may or may not help with emotional distress. It enables individuals and families to know their risk. If you're in a telomerase mutation family and you don't have the mutation and you have normal telomeres, then I think you don't have to worry, but I would include both of those. In the interest of time, it is now possible when the genetic mutation is known to prevent transmission. Those can be expensive in vitro fertilization, but in some circumstances, genetic mutations are severe enough that all of us would not want to choose a child to have some tragic diseases, and now there's methods that can prevent that. They're complicated and can be expensive, especially in our healthcare system, but it is physically possible for those to be enacted, and it's done in many tragic neurologic diseases. There are many cases where people have had their own biologic children without the GSS mutation or other diseases. So in conclusion then, panels of telomerase and surfactant pathway genes are readily available. In the past, we would send one or the other panel. Now you can send a panel that through sequencing all of the coding portions of genes, whole exome sequencing, it's possible to test all of the genes. We have jumped from lab to lab because they did not, each one of them may not have offered the most recently described one. Gene from TERT to then RTEL to PARN. We changed labs so that we could comprehensively test all those. But now there are labs that offer all of those on a whole exome sequencing panel that I think multiple different labs are doing that. And so why not test for all of the known mutations when it's so readily available? When you're testing unaffected family members who want to know their risk, then genetic counseling is very important. We don't have enough genetic counselors. I showed you there are 5,000 different conditions that need to be counseled when genetic testing is done, but fortunately we have Janet Talbert. You can email her at National Jewish. I'd ask all of you to do that on Monday so she can stay busy. And I think we still don't know how often or the extent that occult genetic disease participates where you can have short telomeres in a family. But I think it's very important. We've seen several patients in that circumstance in families that's not well represented in the literature yet. And we can't prove that those individuals in families with severe pulmonary fibrosis, some of whom needed lung transplants and who have short telomeres but don't have the family mutation, it's always possible that they have some other cause for their pulmonary fibrosis. But we've seen it several times and we don't see any other cause to explain it. Smoking probably does play a role. So if you are in a family, then the most important thing is that nobody smoke. It increases probably threefold the risk of individuals who have the TERT mutation or one of the other ones of developing disease. And so I hope that we've represented all of these in a recent publication in the Blue Journal that describes the points that I've talked about today. Thank you for your attention. I think we're going to have a session at the end to take questions.